Systemic Lupus Erythematosus and Cutaneous Lupus Erythematosus. Definition: SLE is an autoimmune disorder that affects many different organ systems. Cutaneous Lupus Erythematosus, CLE, is a disease state distinct from SLE and can occur either alongside systemic disease or without any internal organ involvement. Stated another way, most patients with SLE have CLE, but many patients with CLE do not have SLE. CLE may manifest with virtually any kind of skin lesion, including macules, papules, plaques, bullae, purpura, subcutaneous nodules, and ulcers. The face is frequently involved. Different types of skin involvement have discrete rates of systemic involvement. The most important types are acute cutaneous lupus erythematosus, ACLE, Discoid lupus erythematosus, DLE, and subacute cutaneous lupus erythematosus, SCLE. Nearly all patients with ACLE have SLE. DLE and SCLE are scaling disorders, and most patients with these types of CLE do not have systemic disease. For generalized erythematous eruptions, SLE should be considered a possible, although uncommon, cause, particularly when other signs and symptoms of the disease are present. Systemic lupus erythematosus, butterfly rash characterized by erythema with or without telangiectasia. Incidence. In the United States, the number of women with SLE outnumbers men with the condition by approximately 9 to 1. SLE occurs more commonly in certain racial and ethnic groups, in particular Black, Asian, and Hispanic populations compared with white populations. Women of childbearing age are most commonly affected. History. With active SLE, fatigue, fever, arthralgia, and weight change are the most common constitutional symptoms. Mucocutaneous symptoms of SLE include nasal and oral ulcerations, photosensitivity, CLE, alopecia, and Raynaud phenomenon. Arthritis is common. Serositis, with pleuritis or pericarditis, and neurologic manifestations, headache and seizures, may also occur. Systemic lupus erythematosus, erosion on hard palate. Because both SLE and CLE can be drug-induced, a careful drug history is important. The drugs most often implicated in SLE are procainamide, hydralazine, quinidine, and isoniazid. These patients tend to develop skin changes of vasculitis. Drug-induced lupus tends to occur in patients over 50 years of age, has a male-to-female ratio of 1 to 1, and symptoms resolve after drug discontinuation. Drug-induced CLE is most commonly caused by tumor necrosis factor inhibitors, antihypertensive agents, proton pump inhibitors, and antifungal medications. Physical examination. CLE often has a violaceous hue. All types are frequently accentuated in sun-exposed areas, but in some patients, they are generalized. The most classic form of ACLE appears on the malar area of the face, where it produces the butterfly rash. The malar rash in lupus tends to spare the nasolabial folds and is frequently accompanied by telangiectasia. This rash strongly suggests the presence of SLE. When present, DLE causes destructive erythematous and scaly plaques with pigment and hair loss in affected areas. SCLE causes ring-shaped erythema in the sun-exposed areas. Recall that DLE and SCLE are less commonly associated with SLE. Differential diagnosis. The diagnosis of SLE is complex and is established by a combination of historic, physical, and laboratory findings. The key takeaway is that the presence of CLE should prompt evaluation for SLE. This evaluation should include historical and laboratory evaluation for the presence of protein or cellular casts in the urine, which would suggest nephritis, a serious complication of SLE, cytopenias, red cell, white cell, or platelets. Neurologic manifestations like seizure or psychosis, history of thrombotic episodes or miscarriage, indicative of antiphospholipid syndrome, confirmed with laboratory testing, historical evidence of pleuritis or pericarditis, history consistent with inflammatory joint disease, and other immunologic phenomena like the presence of antinuclear antibodies, ANAs, anti-double-stranded DNA, anti-dsDNA, or anti-Smith, SM, antibodies, or depressed complement 3 and 4 levels. Historical or laboratory abnormalities prompt referral to rheumatology for further workup. American College of Rheumatology criteria for SLE. 1. Malar rash. 2. Discoid rash. 3. Photosensitivity. 4. Oral ulcers. 5. Arthritis. 6. Serositis. 7. Renal disorder. 8. Neurologic disorder. 9. Hematologic disorder. 10. Immunologic disorders. 11. Antinuclear antibody. SLE is diagnosed if 4 or more are present. Other collagen vascular diseases may be considered in the differential diagnosis, and sometimes an overlap occurs among several of these disorders. Mixed connective tissue disease is an example. In dermatomyositis, the characteristic skin findings are violaceous, heliotrope, edema of the eyelids and erythema of the upper trunk, shawl distribution, upper arms and thighs, flat-topped papules over the knuckles, Gottron papules, and reticulated patches of pigment, erythema, and telangiectasia, poikiloderma, often in systemic distribution. Periungual erythema with telangiectasia, along with ragged cuticles, is virtually diagnostic of a collagen vascular disease, most often dermatomyositis. A key finding of the facial rash in dermatomyositis is involvement of the nasolabial fold, which is often spared in lupus. Scleroderma is less likely to be confused with SLE, but Raynaud phenomenon, although less common in SLE, occurs in both conditions, and some patients have features that overlap the two diseases. A. Dermatomyositis, violaceous, heliotrope, macules of eyelids. B. Dermatomyositis, erythema in shawl distribution. Dermatomyositis, Gottron papules, hyperpigmented papules over the knuckles. Periungual telangiectasia and ragged cuticles in a patient with dermatomyositis. Dermatomyositis. Note the involvement of nasolabial fold. In patients with photosensitivity, causes other than lupus should be considered. The major causes are drugs, porphyria, and polymorphous light eruption. The most common cause of a butterfly rash is not SLE but rather seborrheic dermatitis. Seborrheic dermatitis can be usually distinguished by the presence of the fine, yellowish scale, involvement of the nasolabial folds, and coexistence of a similar scaling rash on the scalp, behind the ears, on the eyebrows, and, often, in the presternal area. Also, rosacea is commonly mistaken for lupus. Like lupus, rosacea flares with sun exposure. The presence of papules and pustules on convex surfaces of the face and the lack of systemic symptoms in rosacea distinguish it from lupus. Systemic Lupus Erythematosus. Papulopustular rosacea. Differential diagnosis for Systemic Lupus Erythematosus. Other collagen vascular disease. Dermatomyositis. Scleroderma. Photosensitive disorders. Drug. Porphyria. Polymorphous light eruption. Seborrheic dermatitis. Rosacea. Laboratory and biopsy. The screening tests for SLE are complete blood count, platelet count, urinalysis, and ANA test. If the ANA test is positive, an anti-DNA antibody test is ordered because it is more specific for SLE. Antibodies to the SM antigen are also highly specific for SLE but are found less frequently than the antibodies to dsDNA. Serum complement is often depressed in patients with active SLE. Antibodies to DNA histones are historically associated with drug-induced lupus from hydralazine and procainamide, but many modern cases are antihistone negative. A number of other autoantibodies are associated with CLE and SLE but are not specific, including Sjogren's syndrome A, SSA, Sjogren's syndrome B, SSB, and ribonucleoprotein, RNP, as examples. Findings of a skin biopsy in lupus include vacuolar degeneration of the basal cell layer with a perivascular and periappendigeal lymphocytic infiltrate. SLE initial screen. 1. Complete blood count with platelet count. 2. Urinalysis. 3. Antinuclear antibody test. Autoantibody test specific for lupus. 1. Double-stranded DNA. 2. Smith. Findings of a skin biopsy in lupus include vacuolar degeneration of the basal cell layer with a perivascular and periappendigeal lymphocytic infiltrate. Therapy. Cutaneous involvement can be treated with moderate to high-potency topical steroids or topical macrolides, tacrolimus, and sunscreens that filter out both short and long-wave ultraviolet light, example, sunscreens that contain zinc oxide or titanium dioxide. An antimalarial such as hydroxychloroquine, Plaquenil, at a dosage of 5 mg per kilogram maximum is used for more severe cutaneous disease that is unresponsive to topical therapy. Antimalarials are also helpful for fatigue and arthritis. In patients with systemic diseases including renal involvement, systemic steroids and other disease-modifying antirheumatic drugs, MARDs, are used. Anifrolumab, a monoclonal antibody to type 1 interferon, received U.S. Food and Drug Administration approval for the treatment of moderate to severe SLE. Therapy for cutaneous lupus. Initial. Sunscreens and protective clothing. Topical steroids. Triamcinolone cream 0.1%, medium potency. Fluocinolone cream 0.05%, strong potency. Topical macrolides. Tacrolimus. Pimecrolimus. Antimalarials, for more severe disease. Hydroxychloroquine 200 mg BID. Alternative. MARDs. Mycophenolate mofetil. Azathioprine. Methotrexate. Systemic steroids. Anifrolumab. Course and complications. In patients with SLE, the 5-year survival rate is now greater than 90%, and more than 80% of patients survive for at least 10 years. Patients with nephritis have a worse prognosis than those without the complication. Men do worse than women. Patients younger than 16 years of age who have no renal involvement have an excellent prognosis. In one large series, the most common causes of death were renal disease and sepsis, often secondary to iatrogenic immunosuppression. Pathogenesis. In SLE, autoantibodies are formed to nuclear antigens, ANA, anti-dsDNA, Smith, but it is unclear if they are involved in clinical disease manifestations. Research on SLE pathophysiology consistently describes abnormal DNA repair following damage, such as from sunlight, increased type 1 interferon expression, increased cell death rates, abnormal clearance of apoptotic debris, and loss of immune tolerance to these exposed antigens. These processes contribute to the inflammatory response in many tissues, including the skin and kidney. In lupus, the autoantibodies are produced by B cells, which appear to be stimulated by activated T cells, higher ratio of CD4+ to CD8+ T cells, that have escaped from the normal mechanisms of tolerance to self-antigens. Genetic factors play a role in many patients with lupus. Familial lupus is well documented. Concordant disease is approximately 30% in monozygotic twins compared with 5% in dizygotic twins. Environmental factors also have been implicated in lupus. Sunlight is definitely involved. Yet there is a perception that lupus is more common in African Americans compared to Africans, suggesting environmental differences that may impact autoimmune disease progression. Clinical case. A 32-year-old woman presents with a 6-month history of recurrent, photosensitive erythematous plaques on her cheeks, nose, and upper chest. The lesions become more prominent after sun exposure and are associated with mild burning but no significant pruritus. Examination reveals well-demarcated erythematous, slightly scaly plaques over the malar areas and nasal bridge, with follicular plugging and areas of dyspigmentation and scarring. There is no nasolabial fold predominance. She reports fatigue and intermittent arthralgia of the small joints of her hands. ANA is positive at a high titer, and anti-dsDNA antibodies are detected. What is the most likely diagnosis? A. Dermatomyositis. B. Seborrheic dermatitis. C. Rosacea. D. Cutaneous lupus erythematosus. E. Scleroderma. Correct answer, D. Cutaneous lupus erythematosus. Explanation. The combination of photosensitivity, persistent erythematous scaly plaques, follicular plugging, dyspigmentation and scarring, together with positive autoimmune serology, strongly supports cutaneous lupus erythematosus, particularly the chronic, discoid spectrum. Dermatomyositis may cause photosensitive facial erythema, but characteristic findings include heliotrope rash, Gottron papules, and muscle weakness. Scleroderma produces skin induration, tightening, and sclerosis, rather than primarily photosensitive inflammatory plaques. Seborrheic dermatitis usually involves the nasolabial folds, eyebrows, scalp, and retroauricular areas, with greasy scale. Rosacea, characterized by central facial erythema, flushing, telangiectasia, and sometimes papules and pustules, follicular plugging and scarring are not typical.